So I'm going to give the floor to MEP Deirdre Clune from Ireland. And first of all, I would like to thank you for hosting this event today with us and for your commitment, because we can see that you have the commitment with Migraine and with our group, and we really appreciate it.
Okay, good. Thank you, Elena. Hello, and good afternoon or good morning, wherever you are, to everybody. And thank you so much for joining the webinar this afternoon, our European Migraine and Health Alliance webinar, focusing on migraine and lifting the barriers to treatment. So my name is Deirdre Clune. I'm a member of the European Parliament. I'm from Ireland, and I'm also a member of the Environment and Public Health Committee in the Parliament here. So, and I've met with members of the Migraine Alliance previously, and I think the webinar that we're having today and focusing on the issues, what are the issues, what are the challenges? More importantly, I hope we'll end up at the end of this with what can we do about it. So as all of you know, it's a very serious, distinct, complex neurological disease. It's very common and yet it's invisible. It affects 41 million people across Europe, and significantly, the disease is 3 times more common in women. So it's, as I said, it's underdiagnosed, undertreated. It's that lack of awareness, lack of education, the clinical issues, clinical social barriers, it's poor access to treatment. Is it misunderstood, ignored? These are the questions, and these are the answers we hope we get today. So look, there is an urgent need to raise awareness among public and policymakers and to help to remove the stigma that's associated with the disease. Maybe when we look at medics, the medical profession, their education, do they understand it? Are they have the capacity to diagnose it? And does the curriculum need to be improved to match the stakes? So there are new migraine treatments coming along all the time, and are all EU members and member states benefiting from that, and do all EU citizens have access to those types of treatments? So the results of the European Migrant Health Alliance Access to Care survey carried out in 2012 and show that a significant number of patients still don't have access to treatments. So we have an EU for Health programme looking at addressing important long-term challenges for health systems, and will that deliver solutions for migraine sufferers and families? I know today we're speaking, marking the European Migraine Day of Action, which was September the 12th, so this is an appropriate time after that to focus on the issues and see how we can move forward. So I'd really like to thank everybody for joining us today, particularly our participants, and their presence greatly adds to raising awareness and increasing the visibility of migraine. So I'm really looking forward to all your contributions, and thanks again to Migraine Alliance for including me and for giving me the opportunity to highlight this issue among my colleagues as well here in the Parliament. I'll pass back to you, Alina, now. Thank you.
Thank you, Deirdre. Thank you very much. And it's true, September 12th was Migraine Day of Action. That's why we organized this event with our Migraine Alliance at the European Parliament. Deirdre is one of the members of this Migraine Alliance in the Parliament, and they have the commitment with us to help us to improve the migraine field, the migraine situation, and all those migraine challenges that we all know. I'm going to share my screen. No, not that. Let me see, because with that stupid migraine, it takes time for me to do everything. But I'm going to share my screen to talk to you about. All right, now to talk to you about the results of a survey that EMHA has run called Access to Care among seven members of the EMHA in 7 countries. Let me share with you those figures, facts and figures and results. It is difficult for me to speak when I have migraine about numbers, but I will do my best. So this is, we got 3,397 responses. We had the survey open for several months, and 90% of the responders were women. Those are the percentages of the responders per countries. So we got the first country was Germany, Spain, Italy, Greece, France, Latvia, UK. We have to say that UK at that same moment was running another different survey on access to treatments too. And that's why the reason why they don't have a very high response, but because usually they do. We will compare our both surveys and results to check what happens in there too. But that's the reason why the UK usually here it has a low. Afterwards, it was Ireland, Norway, Finland, Brazil, and then some others that wanted to participate. And the people who answered had suffered in 80%, 83% of them had been suffering migraine for more than 10 years. 32% of them more than 30 years. Of course, because that's normal for us, for patients to understand, because migraine is forever, for all your life. So the younger you answer, the less years you have been suffering. But the older you are, you answer, you have been suffering for more years. And how many days of migraine per month they suffer? 57% said that more than 5 days per month, but there is a 26% that say that from 8 till 14 days per month, which is a lot. I have to tell you that 14 attacks per month, knowing that one attack takes from 4 to 48 hours, means the whole month. So this is chronic people that have answered mostly this survey. Now, this is an interesting one, and I wanted to share this the answer with you. We have lots of answers, but I have chosen some. I have cherry-picked some of them because it was too long. But this is an interesting one, and it's the difference between the help that we need when we have a migraine attack and when we don't have a migraine attack. And I want to pay attention on that, because the perception that the population has is that this is just a headache. Let's have this in mind. And this is just a not important disease. And this is not a really considerable disease. I have been in several already consultations with doctors, and I had this minor surgery on Monday. And when they said to me, do you have any allergy to any treatment or any medication or anything like this, any other disease? And I say, yes, I have migraine. Oh, they say, they all absolutely always, they say, no, well, that's not important. And they don't even take notes of it. And I get cross with them, because I said, this is my most important disease all over my life. So when we don't have a migraine attack, we don't need help for anything. When we do have a migraine attack, we need help for many things. But more than 50% of the population need help to drive, because we cannot drive. This is clear and this is evident. But it's not that we are talking about 1 or 10% of the population with migraine that they need help for something. No, it's that we are here nearly in the middle, that 50% of the responders needed help for cooking or eating or taking care of the family, taking care of the children. If they have small children, this is a very difficult moment. Even going to the pharmacy, we cannot go out or moving or anything, or even they have problems at their workplace and they need someone to help that helps them. This is important to know, because it seems that we don't need anything and that we are always normal in a normal situation. This is about the patient's journey and what do we need in the patient journey. In the first visit, the first place where we go when we start having those headaches that we don't understand what it is about and so on, is to the GP. So 58% of them went to a GP. And then this is the number of specialists visited to get the final diagnosis. Until they had a final diagnosis, all of those people that first visited the GP went at least, 34% at least, to between 4 and 8 specialists to get a good diagnosis. To get a good only diagnosis, we are not talking about the treatment yet. This is only for the diagnosis. And the person who made the diagnosis mostly in 48%, it's always the neurologist. Now we are going to see the range of, no, too far here. We are going to see about the income of the family income, and this is just a very quick because we have some other data afterwards and we need to understand it. 44% of the responders say that they have less than 40K per year of income, and then 20% of the responders say that they had between 40 and 60, and of course very few other people say that more than 60, or only an 8% more than 8%. That answer is very related or correlated to the countries. This is the answer in the this is the income, this first line here. If you go country by country, this is the income that you saw before. But then the question here was, who pays for your visit in relationship with your migraine, not for your general health, but for your migraine. Who pays for your visit? Well, you can see here that in Greece, in Latvia, in Italy, even in Spain, 60% in Italy, 80% in Greece, 74% in Latvia, 58% in Spain, they pay the visit and treatment, the visit to the physicians out of their pockets. So if we are talking about a social security system, European social security system or national, but in Europe, we all have our systems, our own systems. In many of the countries, still it's not so high in the other countries, but in many other countries, they do pay the visit, or they treat their migraines out of their pocket. And they will keep it doing like this. The report says that they will keep it doing like this, despite they have a very low income. So they devote a big part of their income, monthly income, to the migraine. Now we asked them who pays the anti-CGRP treatment, and I am talking now about the CGRP because this is the most innovative treatment for migraine, and this is the first preventive treatment specifically for migraine that has been researched only for migraine. So only 50% said that it is covered by the Social Security, and the other 50%, it's partially covered by the by the Social Security, or it is covered out of their pocket. This 55% of people that we see here, we are going to see it here also. Have you asked for a chance for a change of the treatment due to the cost? Because we know that those innovative treatments are very expensive. So those 24% of people that answered that they pay them out of their pocket completely, they have already asked a change of treatment because it's extremely expensive for them. But they need it. It's what they need to live. So they are trying to do with other things, but they don't. It's not because they don't like it. It's because they cannot pay for it, and they don't have any other way to access to it. And how much is the impact of the cost of those treatments on your finances? 52% say that yes, it really has a cost on their family finances. Then we asked them how many years since the diagnosis that we spoke before they took until they received a treatment, this treatment in their country. And you can see here in Spain, we are the worst, and they took more, people takes more than 5 years. But in Germany, even in Germany, they take more than 5 years, or UK, this dark blue line is more than 5 years, which is a lot to get this appropriate treatment when you have a migraine severe situation like the one we are talking about now. And this is what they said based on the responses. We asked them which treatment they received when they go to the GPs, and here the first treatment, 64% of the population all around Europe, they receive symptomatic and over-the-counter treatments. When they go the second time, or they don't, they already go to say that that's not working for migraine. This is basic, in very low cases, and over-the-counter treatment works for a severe migraine, but that will, Professor Gosby, who's with us today, will speak more, or can explain this a little bit further. Then the second treatment they receive is triptans or some specific prescriptions in here, and they still receive some over-the-counter. And they start mixing it like this, and they start mixing, and it takes at least seven visitors to receive the appropriated one. So in that 7 visitors, or seven moments that you go to complain to your doctor because you are bad, that means those 5 years that we are trying from one to another treatment or one to another doctor. Then we of those 3,800 patients that answer here, 86% were under treatment. They are treatment, they know it. That's why we can say here that we are talking about expert patients. They are not talking, if we could do this on a corner of a street and ask to people, maybe the figures would change, and it would be maybe more astonished how many difficulties people have. And this is the 5 years that mostly people have to receive the appropriate treatment. And this is important. This is what we asked them: what are the barriers to get the best treatment that they have in each of the countries? And they said, first of all, because in the 26%, because my doctor didn't mention it. The doctor maybe doesn't even know about it. And I can tell you that this is true. I went to my GP the other day, and he said to me, you know, my daughter has migraine, and can you tell me what's the best treatment, or can you tell me what do I tell her? He was the GP, and of course he knows I'm working in this, and he asked me what to do with her daughter that recently had started with migraine, and I spoke to him about the CGRPs and so on, and he didn't know it. He didn't have any idea of what the CGRP treatment is for migraine. On the second row, we have it's not covered by my health system, and the third is that I am not eligible. My doctor says that I am not eligible for this treatment yet, so they are still trying with other types of treatments, and 10% say that it's not available in their country, and 6% have already asked for it to the doctor, and the doctor doesn't know about it. They say that, and 8% said that the doctor says that they don't need it. And then you could have those results split here by countries, and in this one, we see that the 41% say that they are not eligible for that treatment. Without about it, what's eligible? When are you eligible or not for this treatment? When we see here that triptans are very, very much used still. This is what they are at this moment. They are being more prescribed, and again we have here the treatment that are being at this moment more used by our patients. But I want to go to this slide in which we asked them why did they thought it was so difficult to get to the appropriate treatment, and what do they take. So this is what on the first row they take painkillers, then triptans, the topiramate, then Botox, and then the last option, well, then symptomatic and preventive, and then the last option was the anti-CGRP, which we know now that is the appropriate treatment for chronic migraine. And we have seen that most of those responders today were chronic. But in their answers, look at that, they say, they know, you think policymakers, and because you are here, MEP Deidre, I'm going to talk to you, but do you think that our patients don't think about you, about policymakers? And they do, they wrote, they think, they don't get the appropriate treatment because there is a big stigma that comes from policymakers. And this is one of their answers, and they specifically say policymakers. So they know this comes from the government and the decisions taken on the government, and they want to do something, but of course they don't know what to do. Of course, stigma in the healthcare community, people think that because they are not covered by the healthcare system, but why they are not covered if they are approved in all Europe already, or of course the insurances, the private insurances don't have it either. And also, this is important, it's not available in all hospitals or migrant centers yet. Well, this is a summary. This is the first part of the socio-demographic part and so on. But then we can see that 90% of the patients or the responders were already treated, and 49% needed more than 3 years since they got the diagnosis. That they still receive treatments before they get to their CGRP treatment or what they really need. They need to go through the Botox, but Botox is only used in we know that we need to fail the treatment, the preventive treatment to Botox before going to a CGRP, but Botox is only prescribed in 11% of them. So they cannot get to the CGRP until they haven't failed the Botox, and here we have an issue also. And they mentioned that and it's important to say that they mentioned that their doctors didn't even mention about it, or it's not covered by the healthcare system, or they are said not to be eligible for that treatment yet. And this is what I wonder why. I wonder why migraine is so highly disregarded in the world or in Europe. If there is such a big gap between the needs of patients and the current situation, why such a big misperception of the disease? Why migraine affected people don't deserve the best treatment from the very first migraine diagnosis? Why do we need to go through all those many years with other poisons and trying and so on, and not going directly to the appropriate treatment? We do pay taxes as many as anyone else in Europe, but we are hidden. Nobody sees us when we have a migraine attack. We cannot even move from our bed. Nobody sees us. Is that the reason maybe why? Because the people think that we don't need or we don't deserve the treatment, or we don't get the treatment, or the scientific community don't see us in our worst moments, or even the policymakers don't see the problem. Is migraine considered a minor disease? And my proposal here would be, well, why don't we create a think tank inside? We have this Migraine Alliance, MEP Migraine Alliance. Why don't we create or organize a meeting with you, a multi-stakeholder, with Professor Gorby, Iñaki, that will speak afterwards, some of the most expert people in different topics, and try to find a way on how to change the perception of the population, how to tackle this disease, how to really make a change for the next generation. Because we have been fighting, and I can tell you that I have been here only for 16 years, compared with the amount of years that Professor Gorby has in this field is nothing, but science changed. There are new discoveries on science and on treatments, but the perception and the treatment that we receive from the society and the system has not changed at all in those 16 years that I am advocating for migraine. Let me only just present you the new migraine-friendly workplace stamp that we launched on September 12th. And I just wanted to show it to all of you, because this is a stamp that we have created for workplaces to improve the quality of life, to raise awareness, and to give visibility to the workers with migraine. And I would kindly ask you, MEP Deidre, to work with this stamp at the Parliament. Would it be possible to get this, to introduce this migrant-friendly workplace stamp at the Parliament? Could we talk about this? Could we open this discussion and try to create a migrant-friendly European Parliament too? And this is all for today. Thank you very much for your attention. And I'm going to go to give the floor to a patient, to Fiona Duvernay. I hope Fiona is here too. I'm going to close here. And is Fiona here already? Okay, no, Fiona has, all right. So, are you, Fiona, sorry, I couldn't see you because you don't have you can put your screen if you want.
I'm not going to be able to put on my camera. Yeah. Sorry.
Okay. All right. So can you are our patient today. You can tell us about your journey on the access to the treatment.
Yeah, absolutely. I think I'm one of those very typical case studies. I started having migraines when I was 18, when I started university, and for about 3 years I was undiagnosed and I was not even prescribed triptans. I had a bit of a ibuprofen and paracetamol overdose, and then I saw very many GPs, and at some point one prescribed triptans, which really improved my situation. But the thing is, when a GP prescribes triptans, they're supposed to tell you, okay, don't take too many, but I didn't know that, so I took too many, and it made it worse. And it took me 2 more years to actually have a doctor say that I had migraines. And then from there on, I tried pretty much every single preventive treatment up until the point where I moved to Belgium, and I found a neurologist who was very supportive and explained to me that I needed something a little bit more. And he signed me up for, so it was a program for access to Ajovy. It's one of those anti-CGRP, and it was for free. And then, of course, Belgium in July sorry, I'm also having a migraine and I'm also struggling. So the Ajovy got its market authorization in July, so I was able to get it, and it's now reimbursed. But I have to say, I mean, working in EU affairs, having worked at the Parliament, I can tell you that the Parliament is far from being a migrant-friendly place. And this is one of the reasons I actually had to leave the Parliament. So yeah, it's extremely hard to work in an environment that is mostly, especially now, virtual, with chronic migraines. And small changes to the workplace, that, things like changing lights, for instance, these are things that employers think is too much.
Yeah. And
to me, it's unacceptable, because this isn't too much. This is about actually me being able to stay in the workforce. And so, yes, of course, I'm French, so I'm also fighting to get market authorization for anti-CGRP in France, which is not the case yet. I'm very lucky that I'm living in Belgium and that it's the case now. But I'm also very sympathetic of people in France who are still really struggling. Even Botox is far from being approved. So it's a struggle, and I'm quite surprised. I'm quite young. I'm 27, and when I listen to the results of the survey, you think, okay, but it's better now. But it's not. It's really not. And even for young people, it's a struggle. And every single day I get a message from someone saying, oh, actually, you know, this person probably has migraines. This person actually probably has migraines. And then I try to educate people around me, and it's mind-blowing how little information they're given. And it's mind-blowing as well how GPs sometimes give really bad advice. So they know what a migraine is, they know the disease, but they will, you know, prescribe clean juices and things like this. And I find it unacceptable, but it still happens. And there's a huge stigma, especially for people who work a lot with computers. There's this huge, you know, cliche about, well, you work with computers too much. It must be that.
Yeah, then what do we do now?
It's not. It's not that. It has nothing to do with that.
Nothing.
I mean, it may be a triggering factor for some people. For me, it's not. But yeah. So I do think that there's a lot more awareness raising to be done. And I do think that this is something that needs to be done also at the EU level, because it is really unacceptable for countries to not to have access to a certain very, very, very efficient treatment, and to have to go to Switzerland to buy anti-CGRP, if patients even can buy anti-CGRP, you know, to take out a loan for it. It's absolutely unacceptable. And I really do think that the lack of awareness and the lack of public attention to this issue is, yeah, there's really no word for it. It's
we know
a lot of delusion.
That, Fiona, thank you very much for your testimony, because it's very powerful. And this is exactly the reason why we are organizing today this event here with the Parliament. And we know that Deirdre is listening carefully to us. We know that she will do her best, but this is it's also true that if we don't tell them, our MEPs, they don't know it. They don't know that we exist. So that's why we really need to raise our voices and tell them. MEP Deirdre, you raise your hand? No? Oh,
no, I'm just saying I'm listening to you. I'm here. Thank you.
Thank you. Yeah, thank you. Yeah. I know you are behind listening to our cause, but you've seen also with the testimony of our patient Fiona Duvernay today that, and she's a young girl of 27 years old, and she already had to leave the parliament, her parliament work of my post because of her migraine, and he had all these issues with the treatment. She's French, she cannot get it in France, she needs to go to Belgium. There's people asking for a loan to pay those treatments. What's going on? What happens? Why are we in such a situation? Why are we punished like that? Well, I'm going to give the floor now to Professor Gosby, because we are going to see what happens in the field of the professionals. You already know Professor Gosby. He is, I would say, the #1 in migraine in the world. He has been researching for so many years, devoting his life to migraine and to the migraine in the migraine field. And as always, I want to thank you in loud voice for being here with us, because we know how busy you are, but you are always also with the patients.
Let me share my screen. I think that seems to have worked. Well done. Oh, thanks for asking me to speak. It's both a pleasure and a responsibility to speak at this meeting. I have been at it for a while, not as many years as people seem to think, but it's a whole other thing. I was struck, I have to say. I'm a neurologist and I've been interested in migraine ever since my mentor suggested it would be a good idea. That's some years ago. I was struck by MEP Clune's splendid summary of what I was going to say, as though I'd sent her the slides, which I haven't. But she said 3 things about professionals. They need to understand migraine better, they need to diagnose it more efficiently, and they need to manage it better. That's exactly what I intended to say. So MEP, if you've got something you need to do for my 10 minutes, go right ahead, because you already know everything I'm about to say. I was very impressed with that. Your statement about equal access for EU citizens is, of course, important, and recognising barriers to that is important. And I picked up on what Eleanor was saying in the survey. I mean, it's horrible to me that as an educator in migraine, well, I mean, obviously we haven't done our job in this enough, to say that one of the big failures is that doctors don't know about the problem, or that they say someone's not eligible for treatment when they clearly have it. Or it is extraordinary that Eleanor's GP asks her for advice. I mean, what sort of planet is it on where so the barriers are many, and the professional ones I'm going to say a few things about in the next couple of slides. So if I start with why. Why is always a good question. If you don't understand why you do something, then you're probably never going to get anyone to do anything. So in medicine, the overwhelming presentation to either general practice, this is on the left, a study that was done by looking at by asking patients who'd come along to their general practitioner who were coming along for headache to fill out a diary, describe their symptoms, and then experts looked at the symptoms. And you see, if you take all the migraine, and migrainous, which is more or less the same, then more than 90% of people who pitch up to a GP who say headache's the problem why I came along, 90% of them, 92, more than 90% have migraine. So you don't have to be smart to work out. And I tell students when I'm teaching now that if it's not life-threatening type of headache and it's not migraine, either you're wrong or they need to see somebody else. But migraine's a good place to start because it's the commonest disabling form of headache. So that's why so many people come to their general practice. It's not that migraine patients are crazy or they're going to think better to do. It's that it's the predominant cause of disability. It's the predominant cause of disability globally for under 50s in neurologic things globally, which is a big deal. And of course, neurologists, it's said about 1 in 5, this is UK data on headache presentations to neurology outpatients. Obviously, if most people come to the GP have migraine, most of them end up with the neurologist have migraine. It's not really correct because general neurology tends not to see multiple sclerosis or Parkinson's disease as much. It goes to super specialists. And so probably most neurologists would tell you that about 1 in 3 of the people who pitch up to see them will have some sort of headache disorder. And again, it's mostly migraine. So it's easy to make the case for why you should educate more. Why would you want to understand this condition? Because it's actually very common. It's just good value for money in terms of the investment. So and I'm going to start here with not so much barriers. What's the consequence of the barrier? And then I'll talk about the barriers. These are a couple of studies. One, they're both population-based. So you see 160,000 individuals, 1 year of migraine, 11% to about 12%. They're using the rather restricted interpretation of the International Classification of Headache Disorders. So, big picture, in the US, about 40% of migraine patients, if you looked at the whole big picture, ought to be on a preventive, but only about 1/3 of them are. So there's twice as many people who need a preventive who don't have a preventive. That's just crazy. That is crazy for all the reasons that you've already heard. It's whether you think about it humanistically or economically, it's a bad idea. That study was done in 2006, basically published in 2007. It hasn't improved one jot in the last 20 odd years. It's a web-based sample using ICHD-3, 4 days a month of headache, 18,000 cohort, 28,000 people, 28% so are eligible for preventive, 69% sought care, 80% get diagnosed, and about 28% get treated. It's ridiculous how poorly we're doing with this. So the consequence is under treatment. Where does all that come from? Well, it comes from a problem with diagnosis to start with, as the MEP said. If you don't get the diagnosis, you're just sending smoke signals up. And the differentiation between migraine and tension type headache is not complex. Migraine is as the MEP said, it's a central nervous system, it's a brain disorder, it's a complex disorder, and involves pain and many other features that are well described. I don't have to rehearse those. Contrast to tension type headache, which is simply pain without anything else going on. And that sharp line should drive people relatively easily, but it's not doing it. These are this is again, consequences of barriers to care. So this is a large study. About 500,000 people were invited. You see the responders get down. And what they did was to look at the barriers to care for people with chronic migraines, 15 days or more per month of migraine, 16,000 plus patients. So these are big cohorts in population. This is not some problem that just affects 10 people sitting in a corner somewhere. This is thousands of people. That's the proportions. And look what happens. So you've got people with midas. They come along and they to consult. So about 40% will consult some healthcare professional. Many don't. Why? They don't recognise they've got migraine. So patient education in the public is extraordinarily important. They think it's hopeless because they've seen their parents or their brother and sister, because it's largely genetically determined problem. So they've seen it fail, so why bother? Or they've had medicines and they've failed. Of those who consult and get diagnosed, look what happens. Of the consulters, this is in the US, with chronic migraine, 3/4 don't get diagnosed. It's just not indescribably crazy. 24%, quarter of that group get diagnosed. And of chronic migraine patients, half of them don't even get treated. I don't even understand what possibly people are thinking when they get the diagnosis. There's frequent migraine. You know it's a problem, and you don't do anything. I mean, it's just so there's a barrier at every level. And once having understood what the barriers are, I totally agree with Ellen. We need to get together, work out from the stakeholders what it is we do to start to remove them. Migraine's complex. That's part of the problem. These are the symptomatologies. And when you start talking about all the symptomatologies, it first starts to send people crazy. But as you understand them, you understand things like the cognitive dysfunction, this brain fog. You could say that all over the world, and people use various different parts of language, but and of course my accent usually confuses them, but that's another thing. They get what we're talking about. Even the US FDA has started to understand that we need to be taking this into account when we're developing therapies. I just want to make the point that migraine is so much more than, as Ellen said, than headaches. It's a syndrome that has cognitive dysfunction, that has what are called homeostatic things change, like sleep, tiredness, food cravings, passing more urine, and then the pain symptomatology, light and sound sensitivity, smell sensitivity, sensitivity to touch. 40% that we see will have dizziness, will have vertigo, in fact. So complex problem. Now we have treatments, we have choices, and in many ways the treatments choices are a bit of a problem because they sort of flood people. But I do want to make the point here, MEP Clunes, that all of the treatments that have this little what can you call it, flowery sort of thing, like the one with almatriptan or sumatriptan, all those flowery little ones, all of them, the idea or the actual drug was developed in Europe. All of them were developed in Europe.
That's very important.
So how crazy is it? All of the triptans were synthesized in the UK first, except almotriptan, which was first synthesized in Spain. Not a single triptan was developed in the US. Where's all the benefit gone? The whole idea of the CGRP developments is work that was being done in Europe, largely by Lars Edvindsen, myself, and Olesen. So Europe. The idea of 1F agonists, these ditans, very safe drugs to use, the idea of that and all the basic science was done in Europe. We should be proud of this. We should be celebrating what we're doing, what we've managed to achieve. And instead our patients are not having access to them. And let me just make another point. These are the preventives. There might be something you like, something you don't like. But again, I've put up with these little stars, the ideas or the drugs that started in Europe. Beta blockers, Europe. Pazodifin, Europe. Amitriptyline, Europe. Venlafaxine, Europe. Valproate, flunarizine. The angiotensin drugs that our Norwegian colleagues did. The CGRP story all started in Europe. Nerve blocks. Riboflavin, coenzyme Q, butterbeef, all of those nutraceuticals first studied in Europe. Europe needs to be proud of what it's done in migraine at the point where these things are being developed. And I would make the case, and I think that it's something that you probably have sympathy with, that it's not sensible that European patients are not getting the benefit of all the things that have happened. I agree with you, MEP Clunes, understanding the disorder, diagnosing it better and managing it properly. They're all the professional challenges which I'm happy to help people take on. I'll stop there and so other people can get on time. Thanks, Ellen.
Thanks a lot, Professor Gosby. It's incredible to know, and it's incredible that you told us that everything has been developed or researched in Europe. And it's true.
Funny, isn't it? You wouldn't think so. The way we just talked about European access, you wouldn't realise how much work has gone on in Europe to, and we should be proud that these developments are helping the world. Be very proud of it, but also sort of be a bit reflective that it's not helping everyone in Europe.
Yeah, this is so typical, but we should have to have them and take advantage of it too. And well, so let's see what can be done at European level. We have with us today, this is very difficult for me to pronounce, but Katarina Ptak-Bovkerns. I hope I didn't say it too bad. And who's going to talk to us about with Policy Officer, Health Systems, Medical Products and Innovation at the European Commission. Katarina, can you?
Hello, everybody. I would like, first of all, to thank you for the invitation to your meeting. And I was very happy to listen to the results of your survey and to see, first of all, that this kind of very granular assessment of needs takes place with the patient's community. This is indeed one of the challenges we've seen when we look at accessibility problems in healthcare systems in Europe, and we strongly actually encourage member states to make sure that the way they look at accessibility allows more granular analysis of needs, taking into account various characteristics of the patients. So it's a great pleasure to join you. I am the representative of the unit in DigiSante, which is responsible for the analysis of the national healthcare systems. So we are not working on treatments as such. There are other units in my directorate which deal with the pharmaceutical strategy and access to treatments. I will try to shortly present you what you do and address some of the calls I could hear from you, Elena, who presented the survey, and yeah, I will try to explain you how actually this work is to some extent addresses the concerns you see in your patient community. So first of all, you may all very know that we have quite a different framework for working on health systems. It was, of course, due to the pandemic, which has shaken the European health systems. And actually, currently, the Commission is trying to build the foundations for the stronger European Health Union. The idea is to join forces to respond better to any potential shocks, but also to pay more attention to our health systems, to understand better why they were not resilient, and try to invest more efforts in making them more resilient. So the current policy framework is very much concentrated around putting this idea of the European Health Union package in place. This is very challenging when we think of the competences of the EU. So according to the treaty, to the famous Article 168, the healthcare delivery is the responsibility of member states, which means that we as the Commission cannot intervene into how the access to healthcare is organized, how it is provided. We have clearly the role of supporting member states, and I will explain you what instruments we use to support them. The EU Health Union will trigger some institutional changes. So first of all, you might have heard that the Commission is trying to put in place the new agency, European Health Emergency Preparedness and Response Authority. But we are also trying to improve other agencies, the European Medicines Agency and the other agency working on monitoring of public health issues. Another stream of work is the pharmaceutical strategy. So the pharmaceutical strategy was proposed by the Commission already last year. In November, and the idea is, of course, to make sure that we address the unmet medical needs, that we address all the weaknesses related to the supply chains of medicines, and that we also try to put in place solutions to the problems which became more apparent during the pandemic. With access to medicines. Another stream is the European Beating Cancer Plan. This is a top priority of our president. And what we also are working on right now is the European health data space. So the idea is to make a better use of data for the secondary purposes, but also to actually facilitate the use of telemedicine and modern health models in providing care. I cannot shift my slides, I don't know why. It should work now. Access to healthcare, how is access to healthcare framed in our policies? In March this year, the European Commission published the action plan, which includes a set of proposals to enhance the social standards in Europe. So this is the action plan of the European Pillar of Social Rights. European Pillar of Social Rights is a set of 20 principles related to social standards, and one of them is access to healthcare. So access to healthcare is actually this action plan means that access to healthcare is one of the top priorities of the policies related to social. And this action plan is actually announcing some of the initiatives. One is the initiative on long-term care. The idea is to improve access to long-term care because there are still many gaps in Europe. But also the idea is to ensure that we know better what are the needs in terms of access to healthcare in Europe, that we know better which groups are vulnerable, which groups are left behind. That's why the action plan proposed to look at the metrics which is used across Europe. Another announcement was the European Health Data Space, which I've just mentioned. And the Commission is also calling actually in this action plan for investing more in health and care workforce, because this is one of the reasons for problems in access to healthcare, and also to boost digital solutions and tackle inequalities. And following the adoption of this action plan, we in the GSANTE developed some work with our group of experts looking at healthcare systems performance. We published a report on better metrics which can be used to improve access to healthcare. And there is already some follow-up work to this report, which might be of interest and which to somehow addresses what Elena mentioned in terms of the financial burden for patients, because we are putting in place a project with WHO, indeed to help member states to build better policies preventing people from experiencing financial hardship when accessing healthcare. There is a lot of focus on access to treatments, because actually what costs most patients across Europe in terms of using healthcare is actually costs of medicines. So they pay a lot out of pocket to have access to medicines. So this piece of work will look globally at policy solutions which could be developed by member states to ensure that patients don't actually have problems with affordability of care, and that using healthcare doesn't mean for them experiencing poverty. When it comes to the report, which we published in April, it also looked actually very much at the patient's experience. We realized that the data which is used at European level does not actually allow to know too much about the problems of patients. The data is very general. There are problems with the sampling. Not the whole community of patients is included in the European surveys. That's why we tried to look and propose to member states better tools. And the idea was also to look broader, to not only stick to the health sector, but to look actually if there is a better measurement framework to also mitigate the consequences of accumulated disadvantage, whether it's social, economic, or related to health. And of course, the objective was not just to propose metrics, but the objective was also to have a kind of the push for using these metrics for better policies. And I hope that this is what we managed to achieve, because there was quite interest in member states, but also across the Commission departments. So the report presents actually two types of metrics: the redistributive impact of in-kind health benefits, patient vignettes, and also supplementary tools. Thinking of the first tool which we propose, this is actually something very innovative, because we don't have any idea in Europe how much actually well-designed healthcare coverage policies can contribute to mitigate the poverty of patients, and this is indeed what we tried to look at. So. The idea was to put some foundations for a tool which could actually look at the associated impact of paying taxes and the way the social security is designed in mitigating the poverty. So there's some thinking in the report on it, and the work on our side also continues. So we hope to put this tool in practice at certain point. Another tool which is, I think, interesting from the perspective of what you are doing is the patient vignette. So We tried to develop a pilot where we involved healthcare professionals and patients in getting a standard description of care. We couldn't do it for all the health conditions, of course. So we did the pilot for access to dental care, mental care, and for care for stroke patients. So we defined together the standard pathway of care, and we ran a pilot in member states, including healthcare professionals and patients. And actually we found there were very interesting findings of this pilot, which actually showed that we are not on the safe side with many actually accessibility conditions, with access to some services for patients, that there are many gaps which we have not been aware of. So yeah, we recommend the use of such a tool in member states to understand better patients suffer from various gaps in access to healthcare. And the report also provides a rich panoply of other tools which could be used by member states, because indeed there is a need to understand better and quantify better medical needs. So the survey provides many good examples of what could be done to understand better what is at the origin of the problem. Is it the problem of resources? Is it the problem of particular barriers for patients who due to some characteristics suffer more than the others in accessing services? Or is it a problem of healthcare professionals? So there are various tools which actually could be used to see these problems better and to also raise awareness about certain problems, because I understand from your survey that this is actually one of the main conclusions, that yes, we don't know enough about problems of certain groups. And when you have good evidence, you can actually make it to the certain policy level. You can also raise awareness even of healthcare professionals themselves, because your survey shows that that calls for some attention. In our efforts to help member states to improve accessibility, we also work more on actually healthcare workforce issue. We see, systemic problems with shortages. The crisis has also shown that there is a problem of mental care crisis. There is a problem of people leaving, quitting the profession. And actually that only adds to systemic problems, which we've seen already in the past. That's why we have some projects in the pipeline. We selected projects which look at how problems with healthcare professional shortages could be resolved in medical deserts. So that relates clearly to those areas who are either depopulated or who may be rural areas where access to services in general is more limited. But these projects look also more at the retention policies. What should be done at policy level to retain healthcare professionals? And the projects look also at opportunities related to task shifting. So how can we improve team working? How can we share better the burden of work between various professionals? So we hope to see interesting results of this project. We also put in place the joint action. It should happen next year. We are already having the discussions with member states, inviting them to join, because the joint actions implemented under the EU for Health program are actually are actually run by member states. We, of course, participate, facilitate this work, but they are run by member states and they should serve member states. The idea is to improve tools which help to which help to understand better the needs for skills and the needs for professions. So the idea is to enhance planning and forecasting of healthcare workforce. We also work on the Pact for Skills. Now this is also this is the bigger commission project. The idea of the Pact for Skills is to give more attention to the skills which are needed to not only to try to solve the issues related to socio-economic issues related to the crisis, but also to prepare Europe better to the future. And one of the areas where we want this Pact for Skills happen is healthcare. So we are developing with some organization a kind of the partnership which would help us to invest and do more in terms of improving the skills of healthcare professionals. And our unit is also very busy with the new financial instrument, which is the Recovery and Resilience instrument. So we are not many. We are not many. Each of us deals with a few member states. We participate in the assessment of the recovery and resilience plans, which we receive from member states, which are the kind of the requests for funding within this tool. And I'm happy to share with you that actually quite an important proportion of this fund will invest in healthcare systems. Roughly it will be 50 billion euros, sorry. Yeah, we are very happy to see this resilience and recovery plans, including the proposals of reforms and investments in healthcare. I think this is very important to stress because there was no such a huge interest in the past before the pandemic, because other financial tools were already there. For example, cohesion funds were already there, but there was not such a huge interest in investing these tools in healthcare. So we are happy to see that actually all member states will use this opportunity to improve healthcare systems. I also wanted to mention briefly, yes, that this is of course not the isolated funding instrument. There are other instruments which are available and they can, yes, help, they can improve the performance of healthcare systems. They can be related either to yes, improvement of really the operational capacity, healthcare resources, personal resources, but also they can be used to for very specific ideas around research and development, technical support also, so we can help member states to prepare certain reforms in certain areas or prepare investments in certain areas. So there are many opportunities, and in our unit we will also try to put in place kind of the advisory hub. We will see if this idea flies, but advisory hub to help member states to understand what the opportunities are and to use them, yeah, to combine these various tools to improve healthcare systems. I will stop there. I'm very happy to answer to any questions. Anyway, I take note of what is being said, and I will share the findings with the colleagues who work more on the pharma policies, on the treatment side, because this is not in my unit, but I would be happy to share it with other colleagues. So thank you very much.
Elena, turn your mic on, please.
Sorry, I said sorry for that. I thank you very much, Katarzyna, for your presentation. There has been a huge amount of information in your presentation. We see that there are several tools and ways to work with the commission, with your commission. I think the first thing and the easiest thing I thought while you were presenting is maybe we could do a patient vignette on migraine, as you did in the other three. Maybe we could work with you in this next future to see how and where we can place migraine and place ourselves, knowing that you have more than 58 million Europeans with severe migraine, only severe migraine. There is a lot of population suffering migraine, and I think it's a good amount of people that deserves your attention. Thank you very much for that information. And I'm going to give, we are very tight on time. I think we are very late on time, so we need we still have 3 speakers. Everything is being so interesting that we cannot cut each other. But our speaker now, it's also going to be very interesting. And I have to tell you that 3 years, I think it was 3 years ago with the COVID time, I don't know the time, the years, but it was 3 or 4 years ago, I was in a meeting of HTA International with Iñaki Gutiérrez Ibarlucea. He is at that time he was HTA International President. He's nowadays past President and Director of Innovation of the Basque Foundation for Health, Innovation and Research, Coordinator of Osteva Basque Office for Health Technology Assessment. And we were, at that moment, we were talking about the difficulties of the migraine affected people to get treatments and how to get, and I was discussing with him about the HTA issue and could we get easier to the HTA bodies and so on. So I involved him in this problem and in this issue. And we have here with us today Iñaki to talk to us about these HTA issues and problems and how could we do better. Iñaki, I give you the floor.
Yeah, thank you very much, Elena. I will share my screen, and thanks also for inviting me to this interesting conference. And also we hope that the situation of the people with migraine will improve in the future, in the next future, and as soon as possible. And we were talking about the possibilities of HTA, and we were saying, well, don't put I would say don't put the blame on HTA. I think it is HTA, what we produce is information, and finally the blame should be put on who makes the decisions. But anyway, I'm not going to skip my duties, and I will give you some tips why we are in the situation where we are. So how will HTA improve access to migraine treatment? Some disclosures. I've been a grant holder of some European projects, and some of those they could be related also to migraine somehow. And I've been consultant for WHO on universal health coverage and horizon scanning, but collaborating in some countries with the Environmental Development Bank and so on. One thing to start. First of all, it is that we need data in terms of making decisions. And as we say, without data, you are just another person with an opinion. And it is true. And we have seen that very much within the pandemic with COVID-19, that most people have got opinions, but there was a lack of facts. Another thing that is important, it is that making decisions requires information, but information requires also a cycle in which we need to capture data, data storage, data analysis, search, sharing, transfer, visualization, querying, updating, information privacy, and data source. So it is not so easy. And I was saying, well, there is nowadays a project in many senses to centralize decisions on information in Europe. But I was saying, well, one of the things it is that we need to produce local data. So without local data, we are nothing. And another thing that is important in the case of healthcare systems, it is that most of the decisions when accessing to the market, they are made on control settings without bearing in mind that most of the things happen in the real world, and the real world patients are not those of the control settings. The other thing, and I think it is tremendously relevant, it is to say what technology is. That in fact, technology is an answer to our question. And not just some gadgets that we use to try to treat, manage, diagnose, or prevent diseases. And also the issue is, and that is one of the things that I wanted to raise to the audience and those that are working in the area of migraine, but also other conditions. It is, first of all, do we make the correct questions? The second will be, do we try to find the needed answers? Does the whole analysis reflect the perspective of all the actors? And I think it is pretty relevant. And also, do we need to satisfy the different perspectives? This clearly reflects the complexity of the healthcare systems and how first of all, the voices of all the actors, normally they are not here. And on the other side, it is quite complex to try to answer to all the questions and all the preferences or the perspectives of the different actors that could participate in the same problem. The other thing it is how to measure value, and I refer to one of the quotes by Cameron in informal sociology, that he said, "Not everything that counts can be counted, and not everything that can be counted counts." And in reality, that is pretty much applicable to the healthcare system. And in fact, in most cases, not everything that counts is considered when making decisions in the healthcare system. I bring this here, and that is the new HTA definition, and it says, and it is trying to frame the problem that, and then I will talk about around migraine and how it is seen and how it is measured. At least the solutions that are applicable to migraine. First of all, it is the new HTA definition says that it's a multidisciplinary process that uses explicit methods to determine the value of a health technology at different points in its life cycle. So it is considering the value and when it is used and in comparison to the state of the art, and also it could be that it changes along the time that the technology is used. And another thing it is, the purpose is to inform decision making and not making decisions. And this is something that I need to phrase, because it is a process in which we collect information, we assess that information, we make recommendations for this, that is the appraisal, but we don't make decisions. There is a need for a deliberative process in which decision makers, with the aid and in a participative process, makes finally the decisions. And another thing that is important, it is that sometimes it is confused HTA with just cost effectiveness, so the efficient point of view, but it is also to promote an equitable and a high quality health system. Apart from that, it is the process should be formal, systematic, and transparent, and sometimes it is lacking, and uses state-of-the-art methods to consider the best available evidence. And another thing that I feel it is also important, as when I was referring about the consideration of HTA just as a way of sustaining or making the healthcare system sustainable and focus on cost effectiveness or cost, or at least economic implications. It is that it leads also with ethical, social, cultural, and legal issues, and also organizational, and in the last definition includes environmental aspects that are linked to that. The other thing it is, when we were talking about healthcare systems, it is one of the things that we ask, it is which is best. So which is first? It is the technology, or is the problem that technology aims to address. So it is which is first, the who or the what, the egg or the chicken. Well, this is a dilemma that has appeared in many occasions, and I suppose that you have heard in many discussions. And I have a solution, because you need from now on consider that the egg was first, because eggs already existed before chickens to be appeared. But what about health technologies and health needs? Health needs is the what, so it is the question around what it is needed, and health technology is how we can solve that problem. And what is HTA about? HTA is about measuring the value and the values. And one of the things it is, what do we mean about value? And that is tremendously important, because that will refer to the result that finally we are going to obtain. We normally talk about safety, efficacy, cost, access, acceptability, and affordability. But what do we refer to when we mention values? Obviously, it is the cultural facts, the ethical issues, and the social encountering. The question would be, could we separate the values from measuring value? And the answer is no. No, it is impossible, because when we are evaluating things and when we are considering value, we use the values in terms of evaluating that. So, and also the overall value also could vary depending on the perspective, the group of interest, and the context of decision and the context of application. So the value that could be applicable to one person could be different in another person, or in the same person, but applied in different systems, the value could differ. Also, it is a matter of perspective. Here, there is a picture on the how it was thought that the COVID-19 passport. Some of those, they said, well, we are going to increase the safety when traveling or when living. Another thing, well, they are trying to control us. Another one was thinking, well, I will have the chance to have holidays, and another one, well, I will make money. So it is a matter of perspective, how we face the value and the values. And also, as I was mentioning, the value could not be separated from the values. In fact, value assessment in health could not, we need to say that even considering bioethics, safety is related to non-malfeasance, efficacy is related to beneficence, costs are related to justice, and organizational aspects and legal and cultural issues are related to autonomy. So we cannot separate bioethics or ethics and values from the measurement of the value of a solution. So do we need value frameworks for new value frameworks for HTA? And my question is, so what happened to the old ones? Perhaps it is not a matter of methods, and it is not a matter of how we entangle the problems. Perhaps it is the way of presenting them. So in most of the cases we have referred to safety and efficacy, and most of the decisions are based on safety and efficacy, balance between benefit and risk, budget impact, cost effectiveness, and some others. But we need to be reminded that HTA is not just related to that, but it has cognitive dimensions, so creating overview and knowledge and relevant to policy making, normative dimension, so establishing dialogue in order to support opinion making, and pragmatic dimension, so it is to establish the processes that help decisions to be made. And what about migraine? So it is the fact. So once I have framed the problem, it is what about migraine and how we measure? The current approach of measuring value, it is related to safety, efficacy, and cost, quite classical. But where the main drivers of benefits are patients' quality of life, families' burden, societal impact, so social cost, for example, or economic burden, like what they lost, are those ways of measuring the value of a solution sufficient? Well, I would say that we need to include the perspective, and the perspective differ. On the one side, it is the system. On the other side, the professionals, and the third party, it is the patients that we try to put in the center of the problem. But in reality, they are not so. And finally, the society and the perspective of them, and which the values are for them, and how they are the value or what they consider as value differs. In fact, the system look at healthcare resources, hospitalizations, consultations, technologies used, and how they are structured, and investment. The professionals are looking at objective parameters. They are trying to obtain answers for the patients, and also they are trying to diminish the burden to them. So it is the number of consultations and so on. on contrast, the patients, what they are looking for is quality of life, daily life, activity, work days, and especially in the area of migraine, that is tremendously important. So this daily life activity, work days, and which is the burden that they suffer. And from the perspective of the society, one of the things it is that we are losing people in terms of having them solving the problems that we have as a society. So work days lost of patients, caregivers, or families, this is tremendously important. So why we fail and some kind of possible options. So are we measuring the value and considering the values in the case of migraine? First of all, it is who is assuming the burden? In general, the burden is assumed, as we have seen in the survey from Elena, the burden is assumed by the patient and caregivers and perhaps families. And finally, as an ultimate case, it is the society. Who is assuming the main cost? As we have seen, it is not they are not the systems, at least at this stage. It is mostly the society because of the loss of work days, the patients, the caregivers, and perhaps the families. Who could receive the main benefits? I think the society and the patients. And then what to propose? So conclusions, and with this I finish because I'm conscious of the time. First of all, a classical approach to value measurement fails to capture all the perspective, and that is crystal clear. So just having a cost effectiveness approach or the ICER approach, just with the perspective of the healthcare system, fails to have a clear view on which the value and the values that are embedded on them are. The cost effectiveness analysis with a classical healthcare system perspective provides a partial analysis of the burden and the possible benefits. There is a need increasingly to consider PREMS, so patient-reported experiences and its measurement, and patient-reported outcomes and its measurement to figure out where the burden and the benefits are. And the societal perspective seems to be a more accurate approach to measuring value for migraine. And I hope at least I've framed with my low knowledge a little bit the problem, and I'm happy to have also questions from your side. Thank you very much.
Mute myself. Thank you, Iñaki, very, very much. It has been a very clear presentation. But very quickly, because we keep on being tight on time, but it's clear that, and thank you for taking this to the migraine field, taking the whole HTA situation to the migraine problem issue and field. And so it's clear that a new approach needs to be taken, as we show. But who makes the decision to say, yes, we take this new approach? We consider those social, this burden that some diseases have, like migraine, and we are going to make this new decision, new approach.
I think the measurement of those dimensions and the methods are already there. The issue is that the client asks us, and the client are the systems. So the healthcare systems and the society ask us to make those measurements of value appear, because we know how to make a societal evaluation of the cost effectiveness. But one of the challenges it is producing the accurate data on the one side, and also that is demanded by the client. And in general, the healthcare systems are reluctant to make a societal approach to the measurement of value.
So your client is not the patients. We are not the.
No.
Cannot make...
Well, it should be. Ultimately, it should be. It is our main client. If most of us we are working for healthcare systems and the society, the main client should be the citizen. So, but in reality, it is a more partial.
In the healthcare system, and we are having some issues with the healthcare system that still doesn't consider us. So how do we move forward this needle, and we go from having the problem to change the approach?
I do believe that is a matter of citizens and patients approaching to the healthcare systems and demanding to have this new. I wouldn't say these new ways of approaching. I think it is using the perspective that we are mentioning today in the measurement of value, because finally the society is the one that is suffering for this reduction in the value of the things, because of not an accurate management of the patients, in this case with migraine.
Okay, thank you for that. Since I know you very well and we can get in touch, we can think about how can we build this movement from the current situation to the new situation that we already have understood that it's needed in HTA2. And because for me, it's incredibly impressive that in France there is no access to no Botox, no new treatments, no CGRP, and there is still one European country with no access to any of the most innovative treatments of the last 20 years for migraine. And that comes because the HTA body, national HTA body, didn't approve it or didn't accede to it. So let's work together on that and try to find out a solution and start working.
Happy to do so, and perhaps it is nowadays we are doing, or we are approaching to the problems with a different perspective, and we are working. And recently we are going to finalize a project that is called Validate HTA. So it is bringing values to the measurement of value, and perhaps we can publish an analysis on how that affects the migraine and how it can be solved, or at least bring to another framework by which solutions for migraine are measured.
Please do. We will be more than happy you can do that. Yes, I'm going to give the floor now to Juan José Fernández, who is the policy assistant of the European Patient Forum, to talk to us about the universal health coverage, always focused on patients. Juan José, I'm going to ask you for a short presentation because we still need to go to the conclusions. I know this is very badly polite, but I don't know why the time has gone so fast. So please, you are mute. I think we cannot hear you, Juan José. Okay.
Hello, good afternoon. Yes, I've just been unmuted by you. I hope that you can hear me and see me well. Be mindful of the time. I'll try to run through my presentation in a short time. So if okay with you, I will share my screen so you can see my slides. So if you please give me just a few seconds.
Okay. And I remind you that we are over time already. And so we have few more minutes, I hope, from our audience, but I would ask you to give us the main messages.
Absolutely. Can you see my slides in the screen?
Yes.
Okay, well, thank you everybody for joining to this webinar, and thank you very much to the European Migraine and Headache Alliance for inviting me to speak. I'm going to speak to you today about universal health coverage and what it means for patients of the broader population and for patients with migraine more concretely. Well, first and foremost, I'm here speaking on behalf of the European Patients Forum, so just to give you a very brief update on who we are. We are Brussels-based organizations. We are an umbrella organization, meaning that the members are not individual patients, but rather patient organizations, and then they can be working at the national level, then most likely they are non-disease specific, or working at the EU level and then they are disease specific. We've been active since 2003, and in the EU policy making arena, we aim to be the united voice of patients living with chronic diseases. Our vision, and this is something that I will come back, and again will come back throughout my presentations, is that all patients in the European Union must have equitable access to high quality patient-centered health and social care. Now, moving to the thick of my presentation, what is universal access to healthcare? Why is it important to patients? And why is it that important to migrant patients specifically? We've seen in the presentations that preceded me that many migrant patients have issues or problems being treated on time, getting the right medicine. Situations across countries vary. There are health inequalities across member states, and so on and so on. So in defining what is universal access to healthcare or universal health coverage, I'm using these two as synonyms. There are, in our line of thought, 7 principles that need to be taken into account for defining it. Those you may see on the screen are accessibility, patient-centered medicine equity, choice and empowering quality, partnership and collaboration, sustainability and the value of healthcare, and then finally, accountability and transparency. Now, these 7 principles all need to be addressed within these 3 dimensions or these 3 questions, to say differently, that need to be answered to ensure patients universal access to healthcare. One is who is covered, what services are covered, and the proportion of the costs covered. True universal access to healthcare, or true, it's for patients, it must include all patients in Europe, regardless of where they are from, what disease do they need service for, where they base, their level of income, and so on and so on. As for the services covered, it should simply include all services that they need. Understand that there may be limitations to this, but if a migraine patient needs a medicine in a country, he or she should be able to get the same drug in another EU country. And finally, without question, it should be able to get it perhaps not for free, but certainly for an affordable and reachable price, and with measures taken into place if the person cannot afford it. Looking within this topic, but looking a little bit beyond the European sphere, the European sphere, the United Nations define Sustainable Development Goals. There are 17 SDGs, perhaps you know them, and the third of them reads, to ensure healthy lives and promote well-being for all ages. Now, we believe that this means that universal access is enshrined in the United Nations Sustainable Development Goals, because to achieve this goal, universal health coverage must be a reality, at least in Europe, by 2030. Unfortunately, as we will see later in my presentation, we have still a long way to go. Nevertheless, we will propose some options on how to tackle that and how to address that. There are, in our opinion, 5 key areas for action. These are for the European Commission, for the European Parliament, for policy makers, for decision makers, and so on. And these need to be tackled immediately as soon as possible to ensure that all patients across Europe have access to the healthcare they need with no discrimination. These areas of action are providing access to quality of care, committing to sustainable investment in health, encouraging affordability of health products and services, implementing access to a holistic range of health and social services, ending discrimination and stigma that many patients are still facing when facing healthcare. Tackling these 5 and ensuring that they all become a reality at the European level then will dramatically change the situation for all patients, particularly for migraine patients. And health inequalities across countries will be massively reduced, because we see how the situation of one patient in a country may differ a lot from a similar situation of another patient in another EU country, and sometimes with extreme differences. And then to wrap everything up and to conclude, I would like to propose these 4 bullet points that we, and here that we, and here I try to include all of the health stakeholders, including the European Patient Forum, the European Migraine and Headache Alliance, the European Parliament, the European Commission. We all need to do this to achieve universal health coverage for all. These are raising awareness about the barriers that patients still face every day in accessing the healthcare they need. Then we also need to build on current political momentum created by the pandemic, who has put the focus on healthcare at the EU level. And to do so, including the UN Sustainable Development Goal for Health, which is the 3rd one. Then to foster more EU cooperation on access to healthcare, not only between the European institutions and the member states, but also between the European institutions and civil society organizations, and or between member states, national patient organizations and coalition. And finally, to overturn the current trends and change the focus of politicians from a short-sighted cuts in healthcare and decisions on investment to a real commitment to a long-term vision where equity of access is a reality for all patients in the European Union, including, of course, patients living with migraine. Now, that was my presentation. I'll be here if you have any question. Being mindful about time, should you want to ask me something that perhaps takes more time, please feel free to drop an email to the email address that you see in the screen below. It will be forwarded to me, and then I will liaise with you later.
Thank you very
much.
Yeah. Thanks a lot, Juan Jose, and thanks. You have been very short. Thank you for that too, to be tight on time. And I hope we can get to the dream of this universal coverage soon, and or as soon as possible. And if there is something we can do to improve it and to help you to get to it, we are to support you also. Of course, if anyone has a question, it's a good idea. You can send us a mail or send them a mail, our speakers, and we will make them. We will send them to each of them. And now we are going to read the conclusions, or we are going to talk about the conclusions of this meeting. I'm going to give the floor to Annette Dumas. Annette is our European delegate or representative in Europe of the EMHA. Please, Annette, and ladies, we can give the floor to MEP Deidre to close the session. You're mute.
Can you see my presentation?
Not yet.
Can you?
Yes.
All right. Here we are.
Yes. Okay.
Okay. Yeah. So I'll step in because Patrick Little, the EMHA president, apologized he can't be with us today. So I will go very quickly over the migraine challenges because we've heard so much about it. It's a disease that affects people when they are in their most active period of life, whether they are young people at school or whether they are in the workplace. That's something we haven't talked about, and also women being mainly affected by migraine. Otherwise, we've all said that migraine is underdiagnosed, undertreated, and there's a lot of stigma around it, and we need to address that. In fact, this is something that EMHA has done over the past couple of years. And we've done a few research survey in the field of access to work, as we have presented, we have used in the past to motivate our policy advocacy. The Eurolight project results are also heavily used in our communication, value of treatment. And as Elena said, we have just launched a migraine-friendly workplace stamp to raise awareness about migraine in the workplace, but also to make sure that people with migraine are on equal footing with employees and can remain in their job, and of course also access a job despite their disease. We've done some awareness raising and advocacy work through our webinars. So we had the missing lesson webinar in 2020 when we pointed out that the medical education in migraine was badly scarce and needed to be improved. We also focused on women and migraine and provided some policy recommendations for a policy paper that we launched earlier on this year. And today, as you know, we are launching this access to care survey. We have our policy has been embodied in the creation of the European Parliament Migraine Alliance, to which Deirdre Clooney is a member. It's a group of MEPs who has agreed to support EMHA and national associations in making migraine EU public health priority. And to support that, we have launched a call to action last year. And today we are launching a statement because very little action has been made in the policy field since last year. So we need to reinforce our call and make sure that we start moving the EU health agenda in the field of migraine. We have done some contribution to EU work, like European Commission consultations on the EU for Health program, for instance. We have also done some work on disability, contributed to the EU disability strategy and gender equality strategy. And we also provided some comments around the EU Social Summit in Porto. And each time bringing patients with migraine in perspective and making sure that they are considered in all the discussions. We have also contributed to the WHO consultation on the action plan on epilepsy and neurological diseases. And as I said, for policy, women and migraine is a key document as well to move the EU agenda. So today we are launching a statement, which is another building block in our policy advocacy campaign, and we need to reinforce our call to action. This is a joint call from a large panel of stakeholders calling for a comprehensive EU policy action. We think about eliminating existing barriers to diagnosis and treatment inequalities people with migraine have to overcome, and also offer them a response to their vulnerability in relation to school, access to work, and especially during the pandemics, like the COVID-19 pandemics, which has had a great impact on the people with migraine. The statement presents the burden of and also sets a list of reasons why we need to act. So there are things that have been said, but we need to repeat them again and again because we need to make some progress. So we have to raise awareness to remove the stigma and discrimination around the disease. We need to make people understand what is migraine and the right of people with migraine to be fully included in society. We also state that there is economic value in addressing migraine. It's much better to deal with migraine rather than leaving people in the dark, and that goes back to the presentation on HTA as well. We must promote migraine prevention and treatment to improve patients' quality of life. That can be illustrated by the work-friendly place stamp that we have launched. And of course, we insist that there is added value in involving patients at all stages. Patients are experts with their disease. They know what they need. They know their experience. They know the hurdles they have to overcome. So they need to be fully included in all discussions, including HTA. And we call for EU and global programs and plans that will support action that comprehensively tackle migraine. We then move on to some policy recommendations. And just to say, the statement will be open to a large public support through EMHA website, just because we need to create a momentum. The more people we have endorsing the statement, the higher the weight will be to support our policy recommendation. We can bring on this huge support to motivate the policymakers, not only at EU level, but also at national level. To date, we have already some supporters for the statement. We have some EU organizations involved in brain disease or just patient or women's issue. We've got EMHA, the European Federation of Neurological Association, the European Brain Council, the European Patients Forum. Thank you, Juan. It's been very instrumental. The European Institute of Women's Health. Locally, nationally, we have Belgian Brain Council, La Voix des Migraineux in France, Migra Portugal, the Latvian Society of Headache Patients, and EMHA Spain. We also have two of our alliance members who supported the statement, Nathalie Colin Osterrier from France and Deirdre Clune from Ireland. And we are very confident that the other alliance members will follow suit, and hopefully many more MEPs. And we also have the International Headache Society who supported us. So already we have some very powerful and keen supporters. We need to expand that, and we count on your support from all of you to make sure that we have the weight we need to carry on arguing for migraine as a health priority in Europe. Thank you very much.
Thank you, Annette. Thanks a lot. Thank you for your presentation. I encourage all of you to go into the website of EMHA, emha.org, emhaalliance.org, and you will find there the statement in which you can click and support it, and you can support the statement. It's important that we are all aligned and together, and that, as Iñaki and our MEPs and our policymakers say, we need to ask to them for help, for support, for changes, and that's what we are doing. I would like to thank all the speakers, Professor Gosby.
If I may, I would ask all of you to share it with your networks, friends and family as well. The more, the better. So
Great.
just make a lot of noise about it, please. Thank you very much.
Thank you. Thank you very much. Thank you to all our speakers, Iñaki, Professor Gosby, and I'm going to give the floor to MEP Deirdre Clune because it's really late today.
I know.
But I have to say that it has been extremely interesting, and really we need those moments. We don't have so many, but we take advantage of them, and we need them to change the situation.
Okay, Alina, thank you. And thank you to Annette as well for the summary, and thanks everybody for your participation. As you say, it's been very interesting, informative, and it's good to get stakeholders together and hear other individuals' different views and what we can do. So really, I'm not going to lay any further. We have a lot of information. We have your statement. We know what's needed. And I think it's been a very fruitful couple of hours. I know 2 hours is a long time on Zoom. So thanks everybody for sticking with us, and we look forward to some positive progress on this road. So good luck to everybody. Thank you.
Thank you. Thank you.
Bye-bye.
Bye-bye. With those close, we can close the session. Thank you. Thanks to all of you.
Thanks.
Thank you.